All right, so today we're going to be talking about interpretation of dental caries. This is on chapter 33 of your dental radiography textbook. Things that we'll be discussing this chapter is describing dental caries, any key terms related with caries, explain why caries appears radiolucent on a dental image. Remember, that means dark. Discuss why dental caries, or discuss the importance of dental caries in relation to the clinical examination. Discuss the importance of caries in relation to the dental examination or dental image examination. Discuss interpretation tips for evaluating caries on a dental image, and discuss the factors that may influence the image interpretation of dental caries. We'll also be able to detail and classify, detail the classification of caries, identify and describe the appearance of incipient, modern, advanced, and severe interproximal caries, identify and describe the appearance of incipient, moderate, severe occlusal caries, as well as buccal, lingual, root surface, recurrent, and rampant caries. We will also identify conditions that may be confused with dental caries, so some things that look like dental caries but aren't, including cervical burnout, restorative materials, attrition, and abrasion. So the purpose of this chapter is to describe dental caries and caries detection, to present interpretation tips and factors that influence caries interpretation, and to produce classification of caries on dental images. So caries is one of the most frequent reasons for obtaining dental images. The description of caries is, caries is the localized destruction of teeth by microorganisms or bacteria. This is also known as tooth decay or a cavity. So what cavities look like intraorally or on a clinical examination. Here is a picture of a hole on the tooth. You can see that little dark cavitation there. That is a result of that microorganisms that have gotten into the tooth and have literally eaten away at the tooth structure. So a clinical exam is not complete without images. And dental images allow for the dental professional to evaluate the extent and severity of carious lesions. Clinical examination and dental images are necessary to detect dental caries. Dental images enable the dental professional to identify carious lesions that are not otherwise visible clinically. They also allow the dental professional to evaluate the extent and severity of the carious lesions. So to detect dental caries, both a careful clinical examination and interpretation are necessary. Some carious lesions can be detected simply by looking in the mouth, and others cannot. So the mirror can be used to reflect light and allow for indirect vision and to retract the tongue. And the explorer is used to detect changes in consistency in pits, grooves, and fissures of the teeth. The explorer is used as a tactile device to feel or to detect any changes in the consistency, such as a tug back or catches, or the feeling of a dental explorer gliding over leather instead of smooth glass. So here we can see a picture of some discolorations that can be observed in the mouth, otherwise clinical. So occlusal surfaces may show dark staining in the fissures, pits, and grooves. The smooth surfaces may exhibit a chalky or white spot or some type of opacity. An interproximal ridge may appear discolored. So in this example here, we see a discoloration on the interproximal ridge. Here, this looks very suspicious, and the doctor may want to see an X-ray of the interproximal areas between these two molars to decide whether or not that is actually a cavity and not just some type of staining. Some teeth may exhibit a discolored area or cavitation or have no visible changes. So caries that occurs between the teeth may be difficult or even impossible to detect clinically. This is why dental images play an important role in these situations. So if you can remember what type of images are taken to check for caries between the teeth, this is bite wing. So without a bite wing, we would not be able to see these types of things or diagnose cavities that are between the teeth. A carious area appears radiolucent because decreased density allows for greater penetration in the carious area. So bacteria that has caused destruction of the tooth will make the tooth less dense in those areas. And that decreased density is what allows for more penetration of the dental x-rays. So the bite wing image provides the dental professional with the greatest amount of diagnostic information. A periapical exposure taken with paralleling technique may also be used, but make sure that if that's going to be used, that paralleling technique has to be spot on. In other words, there can't be any angulation. Dental caries is the most frequently encountered radiolucent lesion on dental images. So the dental radiographer must be confident in the use of interpretation methods and must be able to identify factors that influence the radiographic interpretation of caries. So dental images should be viewed in the presence of the patient always. So with proper mounting, we will be sure that we are not mixing up images from one side of the mouth to the other. You can kind of imagine how bad that can be if we have images that are mounted incorrectly and the doctor uses that and diagnoses the tooth incorrectly. Also, the viewing you should be viewing these x-rays in a room with subdued light that is free of distractions. We want the focal, we want the patients and the doctor to be able to focus on the image and not of any distractions in the room. If you are using film, an illuminator or view box should be used. And you want to make sure that the light around the mounted films is masks. So this is why it's better to use some type of opaque mount rather than some type of clear mount, just because that light will go through that clear mount and it might cause some type of distraction. And if necessary, or of course, if you're using films, a pocket-sized magnifying glass can be helpful. So some factors influencing caries interpretation. So just be aware that these images should be of diagnostic quality. So examples of erroneous diagnosis are improper horizontal angulation on a bite wing image that'll cause overlapping of the contacts, or errors in exposure with improper contrast and density. If you use too much exposure, we can cause burnout in certain areas, which we will discuss later, that can look like caries, but is in fact not. Classification of caries on dental images have to deal with interproximal caries, occlusal caries, buccal and lingual caries, root surface caries, recurrent caries, and rampant caries. So we'll talk about some examples of all of these different types of caries that we can see on the dental image. So interproximal caries is caries or cavities between two adjacent surfaces. Interproximal caries are typically seen on the dental images at or just below the contact point. And as caries progresses through the enamel, it typically assumes a triangular configuration or a triangular shape right below the contact. When it reaches the dental enamel junction or DEJ, it spreads laterally or to the side and progresses through the dentin. These are classified as either incipient, modern, advanced, and severe. So caries found between two teeth can be classified according to the depth of the penetration of the lesion through the enamel and the dentin. Here we see an example of caries that has just begun. We call this incipient caries. It may be a little hard to see on this picture, but if you look very closely at where these white arrows are pointing, we can see this nice white area of the enamel. And just around this area here, we see a very, very small dark shadow. Okay, this caries is called incipient because it has not reached the distal enamel junction, which is this line here. This is where the enamel meets the dentin. Once the caries has reached that DEJ, it is no longer considered incipient, but we call that moderate. In case you couldn't really see or didn't really get a good example of that picture here, this is just a diagram showing that same area here. So where the contacts or where the two teeth meet are right around this area here. And these arrows here are just kind of showing usually where those types of cavities are formed. Here we see an example of incipient decay. Because this decay here has not reached the DEJ, which is this line between the enamel and the dentin, it is considered incipient. However, once that decay does cross that line and it gets into the dentin, which is a softer layer of tooth structure, that is known as moderate decay. And that is where the point of no return is, we call it. And that is when a filling or some type of restoration must be done before that caries reaches that pulp chamber. And once it reaches the pulp chamber, that patient will experience pain and usually a root canal is needed. So incipient interproximal caries, once again, is caries that extends less than halfway through the thickness of enamel. An incipient or class 1 lesion is only seen in enamel. So here we see an example of that here, a diagram of just some incipient caries that hasn't gone really halfway through the enamel yet. And then we can see it very faintly here. This is tooth number 29. And if we look very, very closely, you can see that little dark shadow right underneath the contact between tooth 29 and 30. And since it hasn't gone halfway through that enamel yet, it is still considered incipient. Moderate interproximal caries is caries that extend more than halfway through the enamel, but does not involve the DEJ. So a moderate or class 2 lesion is seen only in enamel. So some doctors will debate that it's only moderate once it reaches the DEJ, but per the book wants to say that it's still in enamel. So a class 2 or moderate caries would go a little bit more than halfway through the enamel. But according to the book and according to any test that you might take for this chapter, for the purposes of this chapter, moderate would be more than halfway through the enamel, but not yet to the DEJ, which is this line here. And we can see an example of that on this bottom picture here. Here's a small carious lesion here, and it does go through halfway through the enamel point. It's very, very difficult to see, but it is there, and it has not reached the DEJ yet. So that is still considered moderate or a class 2 lesion. Advanced interproximal caries that extends to or through the DEJ and into the dentin, but does not extend into the dentin more than half the distance toward the pulp, is considered an advanced or class 3 lesion, which affects both the enamel and the dentin. So an example of that is here, where we have a carious lesion that has gone all the way through the enamel, and it has gone about halfway or less than halfway through the dentin. And we can see an example of that radiographically on this picture here. This is tooth number 19. This is the distal portion of tooth number 19. And you can see here that caries goes right through the enamel, and it even goes halfway through this dentin. So it ends about right here where the top of my arrow is pointing. So that would be considered advanced caries or a class 3 carious lesion. And so this would definitely need to be filled with some type of restoration. Severe interproximal caries is caries that extends through the enamel and dentin more than half the distance toward the pulp. A severe or class 4 lesion involves both enamel and dentin and may appear clinically as a cavitation in the tooth. And so we can look at this picture here. Here, that is a very large carious lesion, a very large cavity extends through the enamel, past the DEJ. It's now more than halfway into the dentin, and it's very, very close to this, this pulp chamber here. So this is a severe carious lesion here. We can see that radiographically here on tooth number 30. This is the distal portion of tooth number 30. Here we can see that that cavity has entered through the enamel right below the contact area. It's more than halfway through the dentin, and it's very, very close to that pulp chamber, which can possibly lead to a root canal if the dentin or if the doctor nicks the pulp chamber during the restoration, or if even being that close to the nerve chamber without even touching or getting or exposing that nerve chamber, it is still possible that the nerve will react poorly and the patient may still need a root canal here. So occlusal caries is an area in the tooth that involves a chewing surface of the posterior tooth. A thorough clinical exam is usually the method of choice for detection of occlusal caries, and this is because early occlusal caries is very difficult to see on a dental image. A thorough clinical examination with the mirror, explorer, and light is a method of choice for detection of occlusal caries. Incipient occlusal caries cannot be seen on the dental image, and it must be detected with an explorer. Moderate occlusal caries extends into the dentin, and if it is visible on a radiograph, so here is a diagram or a picture of what moderate occlusal caries would be, and about exactly how, well, not exactly, but about how far into the dentin that it would reach. And you can see that it's pretty well into the dentin, but here is a radiographic representation of that same classification of occlusal caries. And here we could barely see just a thin radiolucent line. If we can see a thin radiolucent line, that cavity is probably much bigger in the mouth. So little, if any, change is noted on the enamel when viewed on a dental image. Severe occlusal caries extends into the dentin, as we can see here, and appears as a radiolucency. Here, the radiolucency extends under the enamel of the occlusal surface of the tooth. So we're talking about tooth number 30. This looks like tooth number 30 here. And here we can definitely see quite a big shadow underneath, the enamel portion or the occlusal portion of the enamel. Buccal and lingual caries is difficult to detect on a dental image because they are superimposed on the tooth structure. So if seen on a dental image, it appears as a circular radiolucent area. Here on this drawing a representation of a tooth, this can be on the buccal or lingual side. And remember, without using the slob rule, we won't be able to know if that's buccal or lingual. But here we actually see what that looks like. This is not occlusal caries. This is either buccal or lingual caries, and we see a small representation of that here radiographically. Root surface caries involves only the roots of the teeth. On the dental image, it appears as a cupped out or crater-shaped radiolucency below the CEJ. The CEJ is known as a cemento-enamel junction. That is this area here where the dentin ends, where the enamel ends. And here is the cementum or the root surface of the tooth. So that cemental enamel junction here is where they are talking about. The CEJ is not to be confused with the DEJ. The DEJ would be this line here. Instead, the CEJ is talking about this bottom portion of the enamel where it kind of tapers off into the cementum. So early lesions may be difficult to detect on a dental image, but here we have one here, and we can definitely see a cupped out or crater shape right below that CEJ. And here on that radiographic image, this looks like it is tooth number 20. This is the distal portion of tooth number 20. Recurrent caries is caries that occurs adjacent to or under an existing restoration. It appears as a radiolucent area just beneath a restoration, and it is most often located beneath the interproximal margins of the restoration. Rampant caries is advanced and severe caries affecting a number of teeth. This is associated with children with poor diets and adults with decreased salivary flow. And here, all of the teeth have very, very severe rampant caries. It almost looks like Swiss cheese. We would definitely be able to see some type of clues or actual holes in the teeth if we were to look in this person's mouth. Conditions resembling caries include cervical burnout, restorative materials, attrition, and abrasion. These are not caries. They are also radiolucent areas though, and we will talk about these one by one. So cervical burnout is a radiolucent artifact seen on dental images. It appears as a collar-shaped or wedge-shaped area between the CEJ and the alveolar bone. It may also appear as an ill-defined wedge-shaped radiolucency on the mesial or distal root surfaces near the CEJ of the posterior teeth. And see, it's very difficult to see on this anterior image here, but this is where they're talking about. Okay, so below the CEJ, right between the CEJ and the alveolar bone, we see a radiolucent area here. Very slight shadow. This is not cavities. This is what we call cervical burnout. And all this is just how the density on the CEJ is lower. And since the density is lower because it's the junction between the enamel and the cementum, X-rays are going to pass through it a little bit more, and it's going to cause that artifact to appear. And so we see it everywhere. We see these tiny little red arrows. It's just a really faint shadow below the below the CEJ and right above the alveolar crest. So this is what's known as cervical burnout. This is not caries. There is nothing wrong with any of these teeth on this person's X-ray here. Restorative materials such as composites, silicates, and acrylics appear on, or the appearance of an anterior cavity preparation restored with materials that are not radiopaque can be identified by the well-defined smooth outline. Careful clinical examination helps the dental professional determine the difference between a restorative material and restorative caries. So here we see a representation of what may look like caries. This, however, is not caries. There is some type of composites that are known as radiolucent composites. They do not appear on an X-ray. And so here we can tell that it is not a decay because of how well defined and shaped this is. You could tell that this was shaped very carefully by a dentist with a dental drill. And we have nice smooth margins all the way around. Dental caries usually doesn't present itself that smoothly or shaped like that. It's usually a wedge shaped, and this is definitely a box shaped that was prepared by a dentist using a dental drill. This area is very well filled in by a composite material. But again, for a lot of anterior composites that were done in the past, those were known as radiolucent composites, and those do not show, but may look like cavities. Attrition is mechanical wearing of the teeth that may be seen on the occlusal or incisal surfaces of deciduous or baby teeth or even permanent teeth. So when the incisal or occlusal enamel is worn away, the underlying dentin wears away rapidly and shallow concavities may form. Clinical examination enables dental professionals to distinguish attrition from caries. So here we have attrition here. This is not caries here. This is just, I mean, obviously we don't see any enamel that should be up here. This person has worn away all of their enamel by some type of grinding. And this is what we call attrition. Abrasion is wearing away of the tooth structure from the friction of a foreign object. Here, the surface of the tooth is affected, depends on the causative factor. So whatever caused it. The most frequent type is by improper toothbrushing. Clinically, the areas affected by abrasion appear as hard or highly polished defects in dentin and should not be confused with root caries that appears brown and leathery. So here we see abrasion here. We can see this, this band of radiolucency down here. This is not a cavity. What this actually is, this can be caused either by very traumatic toothbrushing. So somebody that use a hard bristle toothbrush and kind of uses like a very hard scrubbing back and forth motion, they can actually wear away their enamel right at the point of the CEJ because it's the weakest part of the enamel. Another thing that causes this abrasion is when people clench and grind. We have very hard forces from clenching and grinding from teeth that are kind of banging together. And naturally the weakest part of the enamel is right down here, right below the CEJ. So as people put forces back and forth on their teeth, this part of the CEJ will actually chip away and we'll get what's called abrasion down here. That's all I have for chapter 33. Please let me know if you have any questions.